One of my family members, pretty cool. So Patrick Kennedy is the former Democratic representative from Rhode Island. Served in the House from 1995 to 2011. He was the first member of Generation X to be elected. AI told me that. He brought national attention to mental health by leading the passage of the landmark Mental Health Parity and Addiction Equity Act, which we'll talk about. Patrick and his wife, Amy, have co-founded the mental health nonprofit, the Kennedy Forum. And he also recently published a fantastic book called Profiles of Mental Health Courage. Dr. Ross Harper is the founder and CEO of Limbic, a UK-based AI company building neuroscience-driven tools to improve mental health care access and delivery. Dr. Harper holds a Master in Arts in Neuroscience from Cambridge, an MRes, which I had to look up, which is a Master's in Research in Mathematical Modeling, as well as a PhD in Computational Neuroscience from the University College of London. And the most important part of Limbic and Dr. Harper's bio is that they're the most recent portfolio company of K Ventures. So please welcome Patrick Kennedy and Dr. Ross Harper. Okay, so Patrick, let's start with you. I would love if you could give this audience kind of the state of mental health in this country, both from a patient perspective, but then also from a care delivery and policy perspective. So it's kind of like, where are we today as we think about mental health?
Well, first, Chris, you said that we are a family that's supportive of one another. I can't say anything without first telling everybody how amazing you are. This is what we do for each other. We all pump each other up. But good for our collective mental health,
totally.
Too. But Chris, I don't know how many of you know, wore the uniform of our country in Afghanistan, was one of those people on the front lines defending our country's national security interest. And I know he pointed out. Thank you. So, okay, back to me.
Yeah.
So I had the honor of writing the Mental Health Parity and Addiction Equity Act, and the only reason I had the honor of doing that is because no one else wanted to sponsor it. And that's because the words mental were in the title and addiction was in the title. So any member of Congress who was thinking about it thought twice and said, maybe if I introduce this, I might get asked if I have any of those things in my family. And I think most of my colleagues figured it would be best if they didn't even bother to even co-sponsor it. So and my brother told me this one time when I was down in Yale. He said, it's so strong when you say you were the youngest member of Congress from the smallest state in the country, but you got to put your name first on a bill that guarantees 160 million Americans finally have their brain treated like any other organ of the body insofar as insurance reimbursement for all illnesses of the brain. And it took us forever to pass it, and we didn't pass it because everyone woke up one day and said, wouldn't it be good if we had our mental health paid for like other areas of healthcare? We passed it because a good friend of our families, Chris Dodd, was chairman of the banking committee in 2008 when the markets were collapsing. And Chris Dodd wrote the whole $800 billion bailout of our nation's banks into our Mental Health Parity and Addiction Equity Act bill, HR 1424, such that now I'm also the sponsor of the federal bailout of Jamie Dimon and all the banks. So that's how we got parity. Now we made progress. President Biden did a fantastic job. Marty Walsh, who's also in recovery, wrote really strong rule saying payers must comply through all of these forensic auditing of their medical management practices so as to determine whether there was any more onerous medical management practices applied to mental health vis-a-vis compared to medical and surgical care. Anyway, long story short, President Trump came in and he pulled that rule. So now we're in a limbo here because the emphasis in our movement is to get care paid for finally. And we've just never paid for mental health and addiction care. So, but there are opportunities in this moment because we have a number of other challenges, and that's quality. So we've always fought for better access, But we also want access to things that work. And you've already heard several of the presenters talk about how a big portion of our delivery system isn't delivering evidence-based interventions. So that's the one area with this moment we're in where we can focus. And so I'll pass it over to Ross because he is helping to have AI deliver more personalized medicine for mental health and addiction, which you've heard earlier, we really have not enjoyed like we have in other areas of healthcare.
Before we hand it to Ross, just give me this. Like, how many people, ballpark it if we have to in America, need mental health care? How many clinicians do we have that can deliver it? Like, what's the supply and demand imbalance here?
So the problem with mental health is we've seen it all in the disease model. The real future is that we treat it as a public health issue. Everybody gets it. And some get more than others depending on their needs. But that's the way we should be thinking about it. We have a disease model. I remember, I may have told you, Chris, when I had the chance to rededicate John F. Kennedy's Special Warfare Center at Fort Bragg, the general who's in charge of all the Green Berets say, we have more mental health for our Green Berets than any other branch of the service. And of course, you'll hear my brother talk about how the Green Berets would visit us at the Cape because our uncle started them. But he said they need more mental health. And we're like, why do the Green Berets need mental health? I mean, they dive out of the plane. They swim underwater for 10 miles without breathing. They hit the beach. They speak 6 languages. They take out their target, and they're reading to their children by bedtime. Like, why do these guys? And he always said to me, Patrick, we see mental health as a force multiplier, which was the first time I'd ever heard that it's not only mental illness, and we've got a record number of Americans locked up in jail because of their mental illness and living on our streets, but it's also mental health. So we need to somehow have almost type 1 and type 2 diabetes, type 1, schizophrenia, bipolar, serious mental illness. Type 2 is the rest of the population that have mental health diagnoses, but ones that can be supported from a more emotional support, mental health support. But the fact that we leave so many people with serious mental illness on the streets and in our jails is hopefully the challenge we can now focus on right now, especially since the president wants to clear our streets.
Yeah.
The question is, what do we do with folks now?
Yeah. So Ross, I'm going to just let you run free here. Tell us what Limbic does and what it is today and where it's going.
Sure, very happy to. I mean, first, thanks for having me. Thanks for letting me crash this family reunion and
happy to have
giving me a window into sort of like Christmas in the Kennedy household. Well, I mean, first off, as Patrick was alluding to there, the supply-demand mismatch that exists in this area of healthcare is striking, right? There are, on average, looking at the numbers, about 1.6 billion people living right now with a diagnosable mental health condition. There are around 2 million trained mental health professionals. So anyone can see that something doesn't add up. And indeed, in mental health care, the mismatch between clinical supply and number of patients that require support is potentially larger than any other specialty area of healthcare. So at Limbic, we're trying to solve for this. It's a workforce supply issue. We're trying to solve for this. And the way we're doing that is we're creating a new tranche in the clinical staffing pyramid. We've got psychiatrists, psychologists, therapists, and now we have an infinitely scalable layer of credentialed AI agents that can deliver patient care directly and 10x, 100x, potentially 1,000x mental health care supply so that we can make this a population-level area of medicine. And so at Limbic, what we did was we built a clinical AI agent that's been specialist trained on data from mental health care. It works directly with patients as an integrated part of the care journey. It does everything from intake, triage, diagnostics, and then delivering cognitive behavioral therapy itself. And it does all of this as an autonomous member of the care team, amplifying the existing clinicians and allowing them to graduate into the role of clinical supervisor to this workforce of AI agents.
So explain that. I mean, are we putting every therapist and psychiatrist out of a job?
Absolutely not. It's the mass promotion of our clinical workforce. We already have this model, right? Limbic hasn't invented it. We already have more junior clinicians supervised by more senior clinicians. What we're going to do now is move everybody up a level and insert Limbic as these clinical AI agents underneath, and that's how we will scale healthcare. Because so much of AI up until now has been looking at back office automation, right? It's how can we automate these administrative tasks? How can we improve these operational efficiencies? All critical, all tremendously valuable. But it's been quite daunting to try and actually have the AI deliver clinical functions and have a clinical effect and be involved in direct patient care. And that's the ambitious goal we've set ourselves at Limbic, because that is the biggest area of healthcare more generally, which is bottlenecked by supply issues, because it's the credentialed clinicians who are the scarcest resource, and we need to find a way to scale them. And to do that, we have to lean in and step boldly into this future where AI can marry with human expertise to deliver quality care at scale.
Yeah, I find whenever I'm telling someone about Limbic, most people kind of immediately go to, oh, well, I don't know if I would really want to go, see a robot on a couch. And I think we need to, get people there. But when I think about it, I kind of go, well, we could put it into every refugee camp in the world. We could put it after every climate crisis. We could deploy these agents, right? We could send them after any school shooting and truly reach people where they wouldn't normally have care.
100%. And I think access to high quality mental health care is something that has been something only a privileged few really can have, and AI can change this. It can be the great equalizer. We've already seen it, actually. We published a paper last year, I think. It was in 130,000 patients in the UK's National Health Service. And we saw that Limbic was pretty convincingly associated with a massive increase in access for minority groups and hard-to-reach communities. They really saw the benefit because they were starting from such a low baseline, and Limbic was able to materially improve access for these groups. So I think we can all get very excited about the possibility to, one day look back on mental illness in the same way we look back with contempt on lead in makeup and asbestos in classrooms. I think we'll just look back and say, it's crazy that people had to live in this scenario, but AI is going to change all of that.
So, Chris, the thing I think is exciting about this is you've heard already from people saying we have a one-size-fits-all model. And mental health, more than anything else, is really the heterogeneity of these illnesses. And the personalization is going to require reams of data from different, both the clinical, the biological, the psychological, the social. You've just got all of this data. And the EMR companies, the Epics and the Cerners and the Oracles aren't going to do it for us in mental health. We're going to need data sets that they're not collecting. So if you're in recovery and you fit, a certain kind of profile, severity, risk stratification, type of addiction, background, all these other kind of personal attributes, you can start to customize based upon the massive data what might be an optimal care journey for you. So you heard from Avela earlier about how they say it's not just how many days inpatient, one size fits all. How many days do you need? How many outpatient? How much ongoing clinical? And by the way, you're doing well. We don't need it all the time, but if you need it, here's how you re-engage it. There's just so much opportunity to actually personalize these care pathways, as they're called now, so that you're not just oh, you go to rehab, out of rehab, good luck. You could actually start to tailor a care for the person.
Where do you, I know, I think DC and Washington is getting spun up on AI as fast as humanly possible, but where do you see the biggest resistance in DC, and what is the kind of conversation that's happening right now around AI and mental health? Is the idea of Limbic exciting? Is it scaring the hell out of people?
So, AWS is really interested in talking to the mental health community. Why? Because they hope to be the grid that all the EMR companies plug into, because they've got additional access to different data sources that the traditional EMRs don't.
Yep.
What's their problem? They don't want to go into this space because of the worry about the privacy, which is unique because stigma's still alive and well. And so, but they have the contract for the CIA. So how do they have a cloud that also has really high protection and confidentiality? So in the mental health community, we need to figure out what do we want in a clinical model and what do we want from a wellness model? Because there's another piece to this that may not need the same gatekeeping because we're just trying to live a healthier lifestyle. And there's other piece of it on the clinical side, you really need to have strong guardrails. And so educating policymakers and regulators about that differentiation. Right now, FDA is going to regulate chatbots. They are, and by the way, our friend Ross here is helping them. So, I mean, it was something, I went and saw Macquarie 2 weeks ago, and we're saying we're worried people are going to get this misinformation because it's based upon the wrong language model. It's going to misdirect people to the wrong services. And they said, well, we're talking to someone from England who is doing something on NHS. And I said, I have a funny feeling who that is. Of course, I told Ross.
Yeah.
Ross goes, that's me. So we're in good shape because he went through this whole regulatory process with the National Health System in England, which gives him a lot of understanding as to what our regulators need to look at as we try to do this through CMS and through FDA.
Okay, so we're going to do question, but let me, someone come up with a really intelligent question while I ask Ross one more. So Ross, two things. I would love for you to give us the scale at which Limbic operates today. And then the other thing that we talk a lot about in my household is using chatbots that aren't therapists as therapists. And if you look at the data, the number one thing people are using chatbots for is for friendship. And I would assume if you follow that one further, there's a lot of therapy going on. So one, what's the scale of Limbic today? And two, are there risks there of me talking to ChatGPT and using it as my therapist?
Yeah, I'll see if I can answer that succinctly.
Okay.
But maybe we pick it up after this. So at the scale, Limbic has now directly supported over 500,000 unique patients as part of routine treatment. So that's in a clinical setting, not in a wellness setting. That's part of healthcare. We've been adopted by nearly 50% of the UK's National Health Service, and we're live in 13 US states with line of sight to 50 state coverage by the end of this year, hopefully. We believe this makes us the largest ever deployment of a patient-facing AI agent in any healthcare specialty for a clinical purpose, we believe. So that's the scale. We're going to keep driving that. And the way we were able to do that was by giving our AI to care provider organizations. Rather than try and be the care provider, we enabled other care providers. We gave them the playbooks, we gave them the technology, and we sought to scale this AI assistant so that it was present at every patient-clinician interaction. In terms of what's happening in the market right now, it's a fascinating space. It's an incredible time to be alive. ChatGPT is absolutely being used for therapeutic chat. I think I'm absolutely fine with that. In a direct-to-consumer wellness setting, I'm absolutely fine with it. It serves a purpose, and it can be tremendously valuable to people. I think the problem creeps in when you conflate wellness with healthcare. These are two separate industries. Healthcare is a regulated, risk-averse industry with clinical bars to entry. And when we allow the boundary between wellness and healthcare to blur, as we have done so often in digital health, that's where risks creep in. And we've already seen newspaper headlines where people place a bit too much confidence or responsibility in an unvalidated generalist AI like ChatGPT, and then tragedy happens. I think as a result, we are likely to see many more examples of that. And the solution is regulation. That's why we're pro-regulation at Limbic. We want to see accountability. We want to see post-market surveillance with this technology, and we want to draw a distinction between consumer entertainment and clinical regulated.
Right.
And the exciting thing is, Chris, in the VA, they had the most robust integrated mental health record in the overall record. So you could now take these AI algorithms and really show the value of mental health in cardiovascular disease, the value of mental health in oncology and MSK. And that, for us in the mental health movement, is a whole new place. We've only been thinking about mental health as a primary diagnosis. The game changer in our movement is when we're starting to be seen as the value add in all the rest of physical health care. And that is why we're in an exciting time in mental health advocacy.
Yes. Dr. Ostrowski.
Ross, thank you for what you're doing. Question for you. In the 13 states that you're in, what percentage of your revenue is from Medicaid? And I'm hopeful that you try to get it as high of a percentage as possible. Patrick, thank you for all of your work. You know how much I adore your work. I'm very curious. I'm fundraising for clinicians to get elected to office. Almost all Democrats, but I did donate to one Republican. He didn't get elected because he didn't take Trump's money. Is there a path to getting centrist Republicans elected to office in this next cycle? And can we get them to support mental health parity and kind of unwind the badness of this administration and advance some of the causes we've been pushing for from a mental health perspective over the last 20 years?
Well, the exciting thing is if the consumer is the goal, then payers and providers have to think about what's the consumer need, because the consumer now can show, hey, if I get this, I have a better shot at getting better. So opposed to mental health being dominated with the tug of war between payers and providers, who's paying for what, if we now know this type of mental health care makes this difference for these people, then there's going to be consumer revolt if we're not paying for that, which is good for payers because they're going to now pay for stuff they know works. It's good for consumers because now they get providers augmented with AI that can deliver much more effective care. So that's where the opportunity on a political, because you're asking political, how do we bring warring factions together? This may be a real opportunity to bring these polar opposites together.
About 80 to 90% of US revenue comes from Medicaid-covered individuals.
Good job.
Do you think
Good work.
do you think a lot of people will pay out of pocket for Limbic one day?
Absolutely. Simple economics. The cost of delivering high-quality care goes near zero. And so I fully believe individuals will pay out of pocket so long as they see it as a clinical tool which has been demonstrated to improve patient outcomes. People just want to get better. People want to recover. And if they can wait months for a clinician to be available, or they can access immediately at the peak of their help-seeking behavior a validated AI that can have a clinical effect, then I'm sure they will pay, yeah.
Okay, we'll do one more. Whoever Jordan gives the mic to. Jordan, a lot of pressure.
Thank you. Thank you. Yeah, great work, Ross, you're doing. My name's KJ. We run a primary care co-pilot. We're also building in the same space, but not just for mental health, but preventative care in general. I'm curious, can you talk a little about the technology, especially because you're being actively involved in the policy-making side of it? It seems like, I'm curious how you're thinking about fine-tuning open source models. Are you guys doing your own classifiers? What makes Limbic special, as well as where do you think regulations should sort of sit, and also what level of laissez-faire makes sense?
Absolutely. We've got a big green clock in front of us right here. You can't see, which is telling me I've got zero time to answer this question. But
talk just briefly about model stack. I'd love that.
Yeah.
Open source, closed source.
We believe that the foundational model companies are solving for naturalistic adaptive language interfacing. So OpenAI and Anthropic, they've got that. We will not compete with them. Where we are investing is on the clinical reasoning systems that sit on top of the foundational models. We call that the limbic layer. And we spent about 5 years with a team of around 10 PhDs in AI building this. It makes the clinical reasoning observable, and it makes it demonstrably protocol adherent and evidence-based. That is how you get the entire product regulated. So you use the LLM for language interfacing, and you have all clinical reasoning held by a separate system that is observable and mechanistic. And
the exciting thing is now, payers have gotten in a lot of trouble, and I'm proud to say the Kennedy Forum has been the chief culprit for creating that good trouble, as John Lewis would say, by taking payers to task for their compliance with the mental health parity law. Now, when they come up with their medical management practices, you're going to have transparent ways to see what works for whom. So this idea of them making up their own medical management criteria, which we saw in a major prominent case in the Ninth Circuit in California, those things are no longer going to be possible. In a funny sense, even though Trump pulled the parity rule, which requires real forensic auditing, this stuff is, with data, is now going to raise the level of transparency so that payers are going to now just have this roadmap, which I think definitely is good for them because they're going to have more predictability that they're paying for things that actually work, and providers are going to know that they can now practice along an area of specialty that can actually help their patients see market change in their functionality and stability in life.
Thank you to Patrick and Ross. Brilliant. Thanks, guys. Great job.